Hello, can you?
Sir, good morning.
Good morning, Rajneesh. There's some issue with the computer here. Like, sorry,
Acha, okay, no problem. Hi, Mohan, how are you?
Fine, sir. Oh, Rajneesh, how are you?
I'm well. तू तो बुढ़ा हो गया यार.
बुढ़ा तो होना ही था ना.
मॉर्निंग रजनीश जी.
हाय, कैसे हैं? गुड मॉर्निंग.
मॉर्निंग.
Pradeep, sir, how are you?
fine.
मोहन, रमेश सर का क्या हाल है?
अरे ठीक है सर. He is all right. As active as
अच्छा,
ever.
आएंगे ना ASG कॉन में?
हाँ, आ रहे हैं. हम भी आ रहे हैं.
ओके. सर, अभी टाइम लगेगा शुरू करने में?
The presenter has come.
अच्छा, तो
Danesh,
your your issues are solved, so we can start.
Danesh,
Presenter has come, sir. Presenter.
let him
Well,
come and then. Yuvraj,
Hello, sir. Good morning, sir. Can you hear me, sir?
we can hear you.
I'll share my screen, sir.
You can share your screen. Can we start?
Yes, please. Yuvraj, please start.
Good morning, Yuvraj. Good morning, Rajneesh, Ramesh, and Mohan. You can take over now for today's.
Okay, Yuvraj, we are ready. Yeah.
Good morning, respected teachers. I'm presenting a case of a 30-year-old male patient who's a bank manager by occupation, hailing from Assam. He came with chief complaint of yellow discoloration of eyes and urine for the past 6 months. History of presenting illness. Patient had history of pain in right upper quadrant, which was associated with bloating, with no history of jaundice or fever, for which he was evaluated and was diagnosed to have polylithiasis. In in March 2023. No history of recurrent episodes of pain. Patient underwent elective laparoscopic cholecystectomy on 10th of April 2023. The duration of operation was around 2 hours. Operative period was uneventful as told by surgeon. Drain was placed intraoperatively, which had yellowish green output since postoperative day 1. Here I would want to know the intraoperative findings. Reason for drain placement was the gallbladder and stones shown to the attenders. Was there any ICU stay, and when was he allowed orally, and what was the quantity of bile output initially? He was discharged on postoperative day 6 with drain in situ, draining 150 ml of yellowish green fluid output. No history of intra or postoperative blood transfusions. No history of pain abdomen, fever, jaundice, or abdomen distension. On postoperative day 15, drain was removed in view of nil output. No imaging or intervention was done. Here I would also want to know the histopathology of the specimen. Patient was asymptomatic for almost 1 year. Then patient started having complaints of insidious onset, gradually progressive, yellowish discoloration of eyes and urine since last 6 months. He also complained of intermittent low-grade fever, not associated with chills, relieved with oral medications since last 4 months. There is history of loss of weight of 20 kgs over 10 months. No history of passing clay colored stools or itching. No history of loss of appetite, abdominal pain. Sir? No history of loss of appetite, abdominal pain, distension or vomiting. No history of prodromal symptoms. No history of hematemesis, melena, postural dizziness, syncope, fatigue, shortness of breath. Here I would also want to know, was there any awareness of lung? No history of blood transfusion. No, here also I would want to know the history of loose stools or steatorrhea present. No history of decreased night vision or dryness of eyes. No history of bone pain or muscle weakness. No history of ecchymosis, fatigue or easy visibility. No history of altered sensorium or decreased urine output. Patient sought local consultation 1 month back where an ultrasound was done and some oral medications were given, and patient was advised to review at higher center for further management. Past history, no history of any comorbidities. History of laparoscopic cholecystectomy on April 2023. No significant family history. Sleep and appetite normal. Bowel and bladder habits normal and regular. Mixed diets. No addictions. Here, my patient is a 30-year-old gentleman from Assam whose status was laparoscopic cholecystectomy done in April 2023 for symptomatic cholelithiasis. Patient had bile leak from drain in the immediate post-operative period, which resolved spontaneously over 15 days time. Now came with progressive jaundice, intermittent fever, significant loss of weight. That is 20 kgs in 10 months since the last 6 months.
Okay, Yuvraj, I think the history is reasonably straightforward in terms of what has happened to the patient. And you pointed out a few points additional points which you wanted to ask. So maybe Dr. Mohan, Dr. Ramesh, can you please take over and let's take this forward?
Yeah, regarding the questions you put, Yuvraj, the missing history, can you elaborate on that? You had asked some specific points which are not there. Why you asked that? And
So here, even though the history says that as per the surgeon, the operative period was uneventful, a drain was placed. So I would want to know the intraoperative findings, what was the actual intraoperative findings and the reason for drain placement, sir. Because the surgery went on for 2 hours. So probably the surgeon had some suspicion or there was
so,
some.
in other words, how would you get that information? In other words,
Sir, if there was, I will see the operative notes. If I can talk to the surgeon.
if the operating notes are available, you can see that.
Or
Sometimes it may not be available.
Operative notes are not available, sir.
Not available. Okay. And why do you want to ask the quantity of bile output initially?
Sir, because I just have one single value which was on post-operative 6, it was 150 ml. So initially was a trend increasing or decreasing. That trend, to see the trend, I would want to know the quantification of bile.
How does it have a bearing? What do you have in mind? What do you have in mind when you say the quantity of bile? Does it have any bearing? What are you thinking about?
So quantity of bile may indicate the severity of the injury, sir. Or not always, but still it gives some vague rough ideas, sir.
It may give an idea whether it is a major bile duct or whatever. Correct. Okay. What about other questions you said?
Histopathology of the specimen to low malignancy, sir. Because he's from Assam and belongs to the Gangetic belt. And later on, he also has significant loss of weight, sir. 20 kgs loss of weight he has.
Is there any point? True, agree. Is there any point in history which gives the diagnosis of carcinoma gallbladder as a less less likely possibility in this history. Maybe, but it can be. But from the history which is given,
Yes, sir. Other than his the place where he comes from and the history of loss of weight, significant loss of weight, there is nothing much contributory to the suspicion of gallbladder carcinoma.
to any point in history which makes it a less likely possibility.
No history of malaise or generalized weakness or loss of appetite, which mostly will be seen in gallbladder
So
carcinoma.
there's a history of that he was completely asymptomatic for 1 year after, which you get the history, I think, no?
Yes.
If you show the history, it was like for 1 year he was totally symptom free, which may make the diagnosis of carcinoma gallbladder less likely. Lower down in your
Yes, sir.
totally asymptomatic for the next 1 year. Okay. And what about lump?
Sir, here I've asked for history of hematemesis, melena, postal dizziness, which are more towards the variceal bleed, secondary to portal hypertension, and here awareness of lump is to rule out sphenomegaly, sir, concomitant sphenomegaly.
Okay. Dr. Rajneesh, Mohan.
Yeah, so Yuvraj, not much to add. Let's go to the next slide, the one which you showed us about the no, the one next to this, the differential. Yeah, okay. So the first diagnosis probably can't be contested too well. It is the second and third where you have issues. So one point which kind of is coming out quite starkly is that patient is symptomatic for 6 months. And we have no history of treatment of somebody having jaundice, recurrent fever for 6 months, which is very unusual. We may not have records, that's a different matter altogether, but those records will play a major role. So when you diagnose carcinoma gallbladder and a history of jaundice for 6 months, and then say it is progressive jaundice, it becomes a little difficult to digest that kind of a history. Everything can happen in clinical medicine, but there's some odd things which stand out, And then the last diagnosis, which again, to my mind, does not really stand the scrutiny. Retained stone in the cystic duct stump. How would you explain this patient's symptomatology by retained stone in the cystic duct stump? You want to contest that?
So the patient, both the bile leak and the obstetrical symptoms could be two different events. There was a leak from an apparent duct which subsided spontaneously, and patient was asymptomatic, but a stone was retained or a subtotal cholecystectomy was done, given the fact that patient underwent a surgery for 2 hours. So probably that is causing an obstetrical jaundice right now, sir. That is what I was thinking.
How do you explain the obstructive jaundice now?
The stone is compressing on the bile duct, sir, on bile duct. Large
So why
stone.
not? So why not diagnose a CBD stone? Why start the possibility of an indirect compression?
CBD stone is also possible, sir. Patient might have, sir.
So when patients have problems in the post-cholecystectomy period, which can be either altered LFT or jaundice or whatsoever, then only two diagnoses broadly come into being, and the rest of them are a little lower down. And that is that somebody's injured the bile duct or there's a stone in the bile duct. That's how we start off whenever we have post-cholecystectomy issues. Correct? So I'm a little surprised as to why CBD stone was not kept as one of the differential diagnoses. Retained stone in cystic duct stump, obviously it can be possible indirectly causing jaundice and so on and so forth, but I would consider it a much lower possibility. And then again, when you consider carcinoma gallbladder as a second diagnosis, remember that the patient has had jaundice for 6 months. And then you say it's progressive jaundice, no pruritus. These are tight obstructions when they happen, when it's malignant obstruction. So again, it becomes very difficult to explain the patient's symptoms with the diagnosis of carcinoma gallbladder, especially with a 6 months history of jaundice and fever. So these are three few points. Mohan?
Yeah, I think bile duct injury and CBD stones come first. obviously carcinoma gallbladder because he's in that area and always it has to be kept in back of the mind. The one thing which I don't know how to explain the weight loss of 20 kgs in 10 months. Uh, this is because of fever or if he is having such symptoms, he must have got some medical attention and some treatment has to be had. But
Yeah.
this one thing which can't be explained. Very
But
difficult to explain.
Yuvraj, does he say that he has actually measured his, if he has taken his weight, usually these people would have gone to some hospital because it's unlikely that he has taken his weight by himself. So, and there is no history of taking, as Dr. Rajneesh said, no history of hospital visits in the last 6 months. So, I'm not sure about this. How correct is this 20 kg weight loss?
He
Whether
did
it is
not take any
documented or not.
treatment, sir, elsewhere. He just neglected the symptoms because they are not affecting his lifestyle.
Yeah, that's what. So, it is not sure whether we can rely on this 20 kgs, 10 months weight loss.
Yeah.
And definitely, CBD stone should come before SSH stump stone.
Okay, can we move forward with the examination?
On examination, patient is conscious, cooperative, well-oriented. Patient is moderately built and poorly nourished. Here I would want to know the hydration status. Here his height is 165 centimeters and weight is 48 kgs. BMI is 17.6. ECG status is 1. Breath holding time is 40 seconds. He's afebrile. He's icteric. There's no pallor, cyanosis, clubbing, lymphnopathy. Also, I would want to know the left supraclavicular lymph node. Pulse is 76 beats per minute, BP is 100/60, respiratory rate is 15 cycles per minute. I would also want to know the signs of malnutrition here. No signs of liver cell failure. On per abdomen examination, on inspection, the abdomen is flat, umbilicus is central and inverted, all quadrants moving equally with respiration. Healthy, primarily healed port side scars are noted, no peristalsis, sinuses or engorged veins, no flank fullness. Hernial orifices and genitalia appear normal, renal angle appears normal. Palpation, inspectory findings were confirmed, abdomen soft and not tender, liver and spleen not palpable, no palpable lumps. On percussion, liver dullness in intercostal space, liver span is 14 centimeters in right clavicular line, flanks are tympanic. On auscultation, normal pulse on third. Digital rectal examination, normal sphincter tone, gloves stained with normal feces, no clear cut stools. I would also want to know if there were any deposits. Respiratory system, CVS and CNS examinations were normal. To summarize, my patient is a 30-year-old gentleman hailing from Assam whose status post laparoscopic cholecystectomy done in April 2023 for symptomatic cholelithiasis. Patient had bile leak from the drain in the immediate postoperative period, which resolved spontaneously over 15 days' time. Now came with progressive jaundice, intermittent fever, signs of with significant loss of weight since last 6 months. On examination, patient was poorly nourished, is icteric with healed port side scars and without signs of liver cell failure. My differentials would be post cholecystectomy bile duct stricture. Second, I would like to keep choledocholitis and rest of my other two diagnoses later on.
Okay, I think you would probably now agree that CBD stone should have been there. We can debate as to where it would be. I would definitely place it as second. And while one wants to consider carcinoma gallbladder and other uncommon diagnoses, they'll be lower down in the order, definitely. This, this kind of flag which is every time raised, signs of liver cell failure. To my mind, in clinical medicine, unless the patient is overtly having a chronic liver disease, it becomes very difficult to justify this. But it's become convention to put this every time there. So just bear in mind that there are times when you get into a viva about what really are you talking about in terms of liver cell failure, what are the signs, what do they mean, and so on and so forth. So I'm not going to debate it here, but please bear in mind that there are occasions when this is not taken very kindly. So please, Dr. Mohan, Dr. Ramesh, would you like to?
Yeah, Yuvraj, tell me something about the healed scar. Is it significant enough to know where are the ports? How many ports are there?
Yes, sir. I want to know the how many ports were. Was it a standard 4-port laparoscopic cholecystectomy or were there any additional ports added to help the surgeon to complete the surgery, sir?
And the most important to me is the site of the epigastric port. What we have seen is many violent neck injuries, so that port is much lower down. And I think there is one important thing we should see in the examination, the site and number of ports which are there in the abdomen.
Okay, Yuvraj, so how do you want to go from here? How do you want to confirm this diagnosis that you have?
Sir, before I would, if possible, I would want to review this previous records, starting from the pre-surgery ultrasound or the imaging report and the ultrasound along the intraoperative findings. If there was any video, I would also want to see or talk to the surgeon at least. And if not, I would also want to know the ultrasound which was done before referring the patient to the tertiary care center.
Okay. Do we have those records, the organizing team?
I think the operating notes are not available, but that's what they said.
What about the pre-operative investigations? Are they available as the candidate is asking for? So I assume they're not available.
They're
Let's go forward.
They're available, sir. I'll show it.
Okay.
Sir, there was a contracted gallbladder with a large stone of size 2 centimeter, which was impacted in the neck, sir. However, there was no ISPD they haven't commented, sir, in this.
So what were you looking for? Why did you want this ultrasound to be reviewed?
Sir, this gives me an idea because it was an impacted stone of size 2 centimeter. I would expect a difficult cholecystectomy during the surgery, sir. Probably the gallbladder would have been distended, mucosine, or an impairment type of which would have been there.
But the gallbladder is contracted, right?
So gallbladder was contracted. So.
So it doesn't really corroborate with the impacted stone theory.
Additions, callus section would have been probably difficult.
So in effect, what other features are you looking for on a pre-operative ultrasound to say this would have been or this could have been a difficult cholecystectomy? Because this can well be a prospective scenario. You have a patient with ultrasound coming for a lap chole. You have to then put the patient into risk categories of difficult versus easy lap chole. How would you separate the two?
So factors in this are he's a male patient and the gallbladder was contracted and the stone of size 2 centimeter impacted at the neck of the gallbladder. So these are the features pointing towards.
Anything
What are
else
you
from the
looking?
ultrasound?
Yeah, other features also. No? There can be several other features.
From the ultrasound, what additional information are you looking for, which may indicate a difficult?
Here they haven't mentioned about ISBRD, sir, and there is no cholecystic collection in this patient. So these findings also would add to the difficulty.
The wall thickness, what wall thickness are you looking for?
Wall thickness of 3 to more than 3 mm.
Okay.
Would indicate difficulty.
Yeah, so there are other features also, as you said, so biliary obstruction, which is ISBRD, CBD dilatation, presence of stone in the bile duct, or stents in the bile duct in some cases, presence of masses in the right upper quadrant, which could be gallbladder or liver also, presence of a thick port gallbladder, collection in the pericholecystic location. which can indicate this is certain. So do you think this was a difficult cholecystectomy?
Yes, sir. Probably, sir.
From ultrasound alone, it becomes very difficult to say what is a difficult cholecystectomy because a lot depends on the other parts of the presentation, which, as you said, male patient. There are other features also, which include surgeon experience, the scenario in which the cholecystectomy is conducted, the location where you are operating, your available armamentarium. A lot of it contributes to what is a difficult cholecystectomy. So I think that should be clear that ultrasound alone does not give you a lot of information, does give you some information about what constitutes a difficult or a risky cholecystectomy. I think some of those points you brought out in the history itself. So you said elective cholecystectomy, and that is the reason you said it. No? I assume that emergency cholecystectomy is supposed to be more difficult, and so on and so forth. Other investigations, do we have those pre-operative?
No, preoperative blood investigations are not available, and the biopsy was chronic cholecystitis.
There you are. So what else do you need? Yuvraj, what else do you need?
The ultrasound report which was done prior to the referral, referred to the nursing center.
So can you review other investigations which are available?
So the old investigations are no more. Nothing else is available, I think. So what do you want next?
So the ultrasound before that referral to the nursing center, which just came on the screen, I would want to know.
Your audio is not very clear, I think.
Ultrasound which was done before referring, sir, which just came on the screen, I would want to see it, sir. I couldn't see it. So the liver is normal in size and contour. Parenchyma is normal, sir. And there is a mild IHPRD, and there is a both right and left duct are dilated, and there is a stricture at the common hepatic ducts. CBD is 3.2 mm, sir. And
So how do you know the intrahepatic bile ducts are dilated on ultrasound? How do you know that they are dilated?
so we compare it with the portal vein, portal veins seen on the ultrasound. And we see
Yeah,
if it is
and the simple thing is, if it is visible, it is most often dilated. If it is visible, it's most often dilated. Yeah. Otherwise, it's not visible. Yeah. Go ahead.
So when was this ultrasound done? I'm not too sure. There's no date on it.
This was done just 1 month before he came to the hospital right now.
So Yuvraj, this is all we have right now. What else do you want to do now from here onwards?
sir, I would like to do two sets of investigations, sir. One is blood parameters I would want to see. I would want to do hemoglobin. You would want to see the hemoglobin counts and platelets and total LFT, sir. LFT panel I would want to see total bilirubin direct and liver enzymes and albumin. If there is any albumin globulin reversal ratio and GGT and INR, sir. And also, I would want to get a ultrasound, repeat ultrasound at my center, sir, before I go ahead. Hemoglobin is 11.5, which is normal, and counts are also within normal range. Platelets are also normal, sir. Creatinine is normal. Electrolytes are also normal, sir. Total bilirubin is direct is also 3.6, sir. Enzymes are also elevated, 133, and OT, SGOT is 133 and SGPT is 82. ALP is also significantly elevated, sir, 696. Albumin is 3.9, which is good, sir. And INR is 1.467, less than 1.5, sir.
Okay, so how do you interpret this?
Sir, there is a obstructive pattern, sir, on the bilirubin, on the LFT. Direct is 3.6, sir. And with some amount of liver cell injury is there because the enzyme ODPT is also elevated and ALP is elevated because of the obstructive etiology, sir. And albumin is 3.9. In spite of him being malnourished, albumin is okay, sir, 3.9.
Okay, so you think that this is obstructive jaundice. So how do you want to investigate further?
A repeat ultrasound, if possible, I would like to get on this patient, sir.
Repeat
Yeah.
ultrasound, same, sir. It will reveal the same findings only.
Then I
So-
would, yes, sir. Then I would do a cholangiogram, MRCP. I would like to do, sir, next with reconstruction.
So let me just kind of put a spanner in the box. Taking your list of differential diagnosis. Your first diagnosis was a benign biliary stricture post cholecystectomy due to bile duct injury, right?
Yes, sir.
That is corroborated by your ultrasound itself and your LFT.
Yes, sir.
How would MR help you in furthering your diagnosis, because you have two more diagnoses left?
Sir, carcinoma gallbladder, the preoperative ultrasound didn't show any masses, and even the histopathology is chronic polycystitis. And the ultrasound which was done now also doesn't show any masses or any lymph nodes. So carcinoma gallbladder is unlikely, sir. The other differential diagnosis is protocol lithiasis, which again is a possibility, sir. So I would want to do an MRCP next, sir.
So based on this ultrasound and the LFT, you have ruled out carcinoma gallbladder, correct?
Unlikely, sir. I haven't ruled it out yet, sir. But
it's time to put your money where your mouth is. You'll have to now commit yes or no, because if you say yes, then you have to investigate. If you say no, then it's fine. You go ahead with whatever you're diagnosing.
I'm not thinking in terms of carcinoma gallbladder.
Not considering, right? Okay, fair enough. But you must understand that MRCP is a non-contrast imaging, and it will not give you any assessment of soft tissues, which may or may not be causing the obstruction. And same for ultrasound, that a small mass can easily be missed. All it can show you is the site of block. So that is why, especially in high incidence areas like ours, this differential diagnosis is taken seriously, and we do investigate, and MRCP is not the investigation of choice for this. Right, so you wanted MRCP. Please go ahead. Can give him control, can you? Yuvraj, do you have control?
Not yet, sir.
You'll have control now. Check. It's-
Here I am seeing the coronal section of T2 weighted images of MRs of the abdomen. If first I would want to see the axial sections, I'm unable to switch to the axial section. Is it possible to shift to the axial
No,
section?
1 minute. You can control now.
Now I'm seeing the axial sections. I don't have the control.
You have controls now. Can you check again?
No, I don't have the control.
You can try controlling, otherwise I will scroll it for you.
Okay.
See.
No, I'm unable to control. So is it possible to scroll it down for me, please? Yeah, here I can write. I can appreciate the right and here the right duct and the left duct. Can you just scroll down a little bit more? Yeah, I can see it forming. No, a little bit more down, please. Yeah, I can. It is just down. Yeah. So just at the confluence, there seems to be a abrupt cutoff, sir. And however, other features are first uh, the liver. There is no any hypertrophy, atrophy which I could see. There is no crowding of bile ducts. There are no filling defects and ISP bilateral ISPAD I can see, sir. And yes, sir. Just at the confluence, there appears to be a transition, sir. Confluence, like not.
Which other image? Which other image in the MR you want to see before you
Reconstructed,
comment completely?
reconstructed images and axial coronal. I would want to see, sir.
Okay, go ahead.
Can you just the confluence doesn't look to be pattern, sir. Looks like a E4 type injury, sir. Right and left appears to be separated. Or there are no any filling defects or stones in the welder. The right, okay.
Devraj, you saw all the images. So any other investigation or part of this image you want to see for diagnosing or ruling out internal fistula?
If it is there, it would have been seen on T2 only, sir. It would have been seen by now, sir.
All of this is T2.
This is a reconstructed image, sir.
So you're saying axial. You're saying axial imaging.
No, sir. Not a coronal, sir. Coronal.
So they showed you the coronal, right? So is that enough to diagnose or rule out internal fistula?
I am unable to comment on the internal fistula, sir. I couldn't make out any, sir.
Yeah. So often the only evidence you have of a fistula is a duodenum approaching the hilum. And it's very difficult to confidently diagnose internal fistula on a image. Very rarely is it so well delineated that you can see it on a MR image as continuity of fluid column. So what else do you want to comment on this MR? Is that enough? All right, or is it anything else you want to see on the MR? Anything, any other information that this MR gives you? Or this all you want to know, and then let's go to the treatment?
From MR, these are the findings I would want to know, sir.
That is all, or
The liver atrophy, hypertrophy, I was able to rule out. There was no any crowding of bile ducts, and there
that
were
you
no
said. That you said.
hyperintense lesions like cholangitic abscess. That is not there.
That you said. That you already said. Anything else?
Sir, nothing
One
that.
thing is very, very obvious, very pointing at your in front of you.
What is the right structure, the right one?
Always have a wider outlook.
I didn't understand the question.
What is that organ on the right side of your screen?
The spleen.
Is it normal?
Here I can only see a limited section. I would want to see it against the two for spleen.
Yeah. What's the impression?
Spleen side looks enlarged, sir, and it is more of hyper intense. When compared to the liver, it looks hyper intense. Probably the liver is more
So
of
what is more important, the size or the hyperintensity?
a hyper intensity, sir.
How do you interpret that? What does it mean? What does hyperintensity of the spleen mean?
Liver is relatively hypointense compared to the spleen because of the ongoing hepatitis. Probably, I'm not sure, sir.
Okay, in a patient, now I'll just give a clinical scenario in front of you. I think sometimes you have to kind of step back and have a look. Patient with a nearly 2-year history, or 1.5 year, whatever you want to call it, a type 4 stricture, and multiple episodes of cholangitis, has an enlarged spleen. Now, can you place into perspective what may be going on?
Then secondary biliary cirrhosis leading to portal hypertension and causing a splenomegaly, or portal vein concomitant portal vein injury with portal vein cavernous transformation leading to a splenomegaly.
So, in this patient, what is more likely?
Secondary biliary cirrhosis or fibrosis, sir, or a fibrosis causing the splenomegaly.
Fibrosis doesn't cause it, the portal hypertension does.
Yes.
Okay, so you basically want to say that possibly we should consider the possibility of secondary portal hypertension, secondary to secondary biliary fibrosis/cirrhosis. And that is an important consideration, right? Yuvraj?
It is important, sir.
Your audio is not okay completely. It is sit closer, I think.
Yeah, it kind of disappears in between, so you lose your voice. Okay, so the spleen is enlarged, and this is what you have. You could have commented on the portal vein also. You could have commented on the splenic vein size, the gastroesophageal junction collaterals. They can be commented on, if not confirmed, on a T2MR imaging. You can use this to say further that I need more investigations or not.
We need more CT.
Sorry?
CCT abdomen, I would like to get it done to confirm the findings, sir.
Which findings?
The status of portal vein, splenic vein, varices, and also to rule out vascular injury, sir, which has happened. To document the vascular injury during the primary surgery. These findings I would also want to confirm on a CCT abdomen, sir.
Yes, Dr. Mohan, you were saying something.
Yeah, Yuvraj, certain things like you told about the splenic vein size, it is much can be found on portal venous Doppler rather than a CT. Then varices can be found by other investigation rather than getting a CT done. Vascular injury, as of MR, there is no atrophy hypertrophy complex, so vascular injury is very less likely. So I think we should go stepwise and not jump onto uh, uh, the other imaging. Either you should have done that first, then MR, or you get the MR, get the information and evaluate. I think you should get a OGD done before for confirming varices or portal hypertension.
Yuvraj, is there anything else on this MR or in general in cross-sectional imaging features of portal hypertension, which seems to be here in this image also? Can you scroll the MR a little bit? Yeah, stop there. Is there anything else?
Caudate, sir, looks enlarged.
Yeah, caudate looks hypertrophic. Yeah, you didn't mention that. Yeah. So always look for other things. No, you're not commenting on the spleen at all. You're looking only in a narrow way, only the liver. Okay.
Yuvraj, so CCT in a patient with a post-cholecystectomy biliary stricture. So what would be the indications? Not this patient. Let's just give us a general idea of why would you get a CCT in a patient with a post-cholecystectomy benign biliary stricture? What are the scenarios?
Sir, to rule out vascular injury, sir, if there is any polygenic abscess, multiple polygenic abscess which needs drainage, to quantify if there is any atrophy of a particular segment, if it needs volumetry to proceed further, it would have bearing on surgical planning, sir. And if at all there is any features of secondary portal cavernous changes, then to consider even a shunt surgery prior to biliary reconstruction, shunt surgery might be warranted in those situations, sir.
Okay, so this is a patient with a post-cholecystectomy stricture. We suspect there may be secondary biliary fibrosis with some portal hypertension. CCT is not the right investigation to ask for, and that's why I wanted to know the list of. So you said first point was vascular injury. So how would presence or absence of vascular injury make any impact on your management right now in this patient?
It doesn't affect my management, sir, but it is imperative to document it, sir, for medical legal purpose. I feel so.
So this means that we should be getting a CCT in all patients with a post-cholecystectomy biliary injury.
So at our institute, we followed as a protocol, sir. All patients we do.
I won't call it a protocol. You will be doing it as a part of your workup, but I don't think it can be made part of a protocol because there is no consensus across the world that we need to get CTs done in all patients or not. So presence of portal hypertension, let's assume that there's no vascular injury for the time being. Presence of portal hypertension, how does CCT help you?
Sir, venography to the vein diameter, splenic vein diameter.
So Dr. Mohan just said that ultrasound Doppler is far better and far cheaper investigation for the same purpose.
So it will also help us to comment on the collateralization, the collaterals, any spontaneous shunts formation, status of the pancreas, sorry, not thrombosis or splenic SMB status, all these features are better seen. What Doppler is also good. It has high sensitivity, sir. Can be done for elimination.
Yeah, but there is a way you proceed in clinical medicine. You can do everything. You can always justify saying that it's either our institution or a patient can afford it, so I'll do everything. That's perfectly all right, or probably from modern medicine, that is the way things happen. But it would have been far more useful for you to say that I would have gotten an ultrasound Doppler first. And there's any doubt persisting thereafter, I can use a CC2 to confirm or revert or refute those findings. Because there are only a few very definite indications of a CCT. One of them, obviously, we discussed right in the beginning, and that was a mass lesion or a suspicion of a CA gallbladder. And the next you said, which I agree, is a atrophy hypertrophy complex where you are finding it difficult to justify whether you should be doing a liver resection or not. And third, possibly you can justify by saying multiple abscesses, and ultrasound may not give you a wholesome picture of the same thing. But thereafter, the indications of CCT become very, very fluid, and you need to justify those indications. Why would you promote CCT over and above a ultrasound Doppler in other cases? So yes, Dr. Mohan, Dr. Ramesh, please.
So what next? Yeah. Do we have the Doppler report? Yeah. Do we have a Doppler?
No, sir, we don't have a Doppler.
Okay. So do we have a CT, or as he said, or no?
No CT was done for him.
So
Rajneesh, sir.
you want upper GI endoscopy?
It's a grade 1
Yeah.
crisis. There is portal hypertension. So now I would get a Doppler confirmation.
What do you mean by grade 1 esophageal varices? Just to complete the discussion.
It is less than less than 5 for varices.
Is or how do they look for that?
So we'll have to
You're
become
sure
a
it must
little
be-
more, you'll have to become a little more
Yeah,
savvy
you
with
need to-
endoscopy findings. Otherwise, you get all kinds of bizarre reports and you don't know how to interpret them. So in an ordinary exam, you would have been asked for grading of esophageal varices. So I think we don't have time for that. But you need a
Yeah.
Valsalva to actually diagnose a grade 1 varice. And then also say that grade 1 varices could well be a figment of imagination of the endoscopist rather than true portal hypertension. So you might need to corroborate that with the portal vein diameter, with other things, and then take a call whether it is truly portal hypertension or just the endoscopist is over imagining things.
So there's a subjective nature to that. Yeah. Go ahead.
Sir, before I proceed further, sir, if I can possibly rule out a portal hypertension, then based on that, I will plan further, sir. Patient also has he's nutritionally, although even though his albumin is 3.9, his BMI is less than 18. I would like to build him up nutritionally. Once all this, and wait for the there is some amount of liver cell injury also, sir. And so in the meantime, I would like to decompress the biliary system, sir, for the LFTs to normalize. Then I would plan for a surgical intervention, sir.
So this is becoming interesting at the far end. So you are saying that you will get a pre-operative biliary drainage done for this patient. So two questions: why, and second question, how? So why is important? You said patient is nutritionally deprived. So BMI, what is the BMI in this patient? I'm sorry, I forgot.
17.
17. That's the usual Indian patient, correct? I agreed, he lost 20 kgs of weight or so and so forth. But in a normal clinical scenario in a government hospital, that's the kind of patients you'll see all the time, 17 BMI. So that is, you said that is one of the indications. Albumin 3.9, difficult to justify it, right? INR 1.46. You want a biliary drainage for that?
Optimizing.
Yes. No, yes, no.
PTPD can be done, sir. There's no enemies, there's no continuity.
Oh, hold on, Yuvraj. INR 1.46, you want a biliary drainage for that?
Give vitamin K before.
Exactly. So vitamin K will reverse it, right?
Vitamin K.
Okay.
But
Hold on. Bilirubin 7.6. You want a biliary drainage for that?
bilirubin is not the indication, sir.
Not indicated. Okay. Hold on. Enzymes 3 times. 130 and what was it? 80 or something? 2 to 3 times.
130.
You want a biliary? Yeah. TLC 7,600 watt, something of that sort. Patient not febrile now. You want a biliary drainage for that?
No, sir, not for counts. Counts are normal, sir.
So I'm still trying to figure out why are you asking for biliary drainage?
Because of his elevated enzymes.
2 to 3 times.
Which will most often get corrected with drainage, surgical drainage or whatever.
So let me just ask you, what do you think is responsible for the rise of this enzyme to the amount that is present?
Sir, universal injuries are obstructive jaundice.
So then this means that all patients with obstructive jaundice will have this kind of enzyme and you will ask for biliary drainage on all of them. I'm sorry, I'm putting words into your mouth now and trying to confuse you. But I think your thought process got derailed somewhere along the way in terms of who requires a preoperative biliary drainage in a patient with a benign obstruction of the bile duct or the biliary tree.
So, in other words, which group you want to drain preoperated? Definite indications. So, this patient has something you would drain.
In case of cholangitis, sir.
Yeah.
Cholangitis,
Persistent symptomatic cholangitis.
During the creatinine deficiency and acute renal failure because of the obstructive jaundice, patient is in coagulopathy. These situations I would consider a preoperative biliary drainage.
Is there any advantage of preoperative biliary drainage apart from just the drainage of the system and your probable improvement of coagulation profile, enzymes?
It also helps in identification of the ductal system.
Yeah. So, but that is not an indication to do it always.
Day prior, in that situation, we do the day prior, not to optimize.
Okay.
So, Yuvraj, you also said, with Dr. Ramesh said that, and you agreed that the only firm indication is cholangitis. That too, probably you will first give antibiotics and hydrate and see whether the patient is responding or not, and then take a call on whether patient needs drainage. So fair enough. But all the rest of it, you said coagulopathy, you said high bilirubin, and you said a couple more things which I'm forgetting right now. All of those are really not firm indications of biliary drainage. And factor in also the fact that this is going to be drained by, I assume it's by PTVD, because obviously endoscopic drainage is out of question. PTVD is an invasive investigation and intervention, and it has its own morbidity as well as occasional mortality. So I think you are taking that particular thing very lightly that, okay, let's get a biliary drainage, so what? You start losing patients to complications of the PTVD, then you start realizing that it is not all that innocuous. So then you'll have to pick and choose. Now, pick and choose is where clinical medicine becomes, discussion prone. And to my mind, I don't think this patient probably needs. Even if clinically not indicated, you could justify it in the end saying that it's a type 4 benign biliary stricture, and hence I might want a biliary tube so that I can identify the bile ducts on the operation table. That's a different game altogether. It depends a lot on the kind of anatomy, kind of experience you have, and so on and so forth. And then when you do it, as you said one day before. So I think biliary drainage in a post-cholecystectomy benign biliary stricture is a different deal from biliary drainage in a patient with periampullary carcinoma, where you are planning a different operation. Or for that matter, in a patient with a hyalocholangiocarcinoma, where you're planning a liver resection. So all these 3 diseases have slightly different, although the ethos remains the same, but the indication in a given patient will definitely change somewhat depending on the scenario. So you remember the scenario, 30-year-old, BMI is 17, in otherwise any other disease and the same kind of patient, would you offer anything else? I think you would just offer some nutrition rehabilitation, you operate. You don't wait for the BMI to change from 17 to 19 to 20, 21 and then operate. Why would this patient be any different? He doesn't have any cholangitis, she doesn't have any cholangitis. The bilirubin is barely 7, which doesn't fit into the classical indication. The INR is correctable by just giving vitamin K. So then the indications of biliary drainage become very, very flimsy the way you're describing it. That's my perspective. Please, Dr. Mohan, Dr. Ramesh.
Yeah, Mohan, you wanted to say something.
Yeah, there is no definitive indication for biliary drainage in this patient. One, this patient is a fit enough patient with a good albumin. This BMI is a very good BMI to operate as such thing. Portal hypertension, yes, the spleen looks big, but the endoscopy grade 1 viruses you have to take with a pinch of salt. That we have to be don't go too much that patient they're going to be a collaterals, not much of collaterals in on whatever the imaging which was shown here. And I think this patient, it's going to be a difficult surgery, yes, but this patient has to be operated, and there is no need for any biliary drainage. Dr.
So
Ramesh?
what procedure are you contemplating, Yuvraj?
Sir, Roux-en-Y hepatico-hydronostomy, sir, probably reimplantation of both the ducts or a hepatoplasty, sir, of reconstruction of both the ducts and doing a single anastomosis, sir.
So the bottom line is that you would attempt a Roux-en-Y hepatogenostomy, basically draining the bile ducts into the biliary loop. How you do it depends on the kind of anatomy you find on the operation table. Attempt is to put them all into one loop, but that does not mean that you do anastomosis to the fibrous tissue. So occasionally, in a given patient, you might want to do two separate anastomosis. There's a lot of fibrotic tissue in between. The bottom line is you should have good drainage, you should have wide drainage, and you should have a healthy duct mucosa to mucosa anastomosis. Correct? That is the bottom line. There are a couple of questions which need probably answers. One is there's been raised in the Q&A box, which is MRCP indications in bile duct injury just after lap chole. Yuvraj, you want to take that first? MRCP indications in bile duct injury just after lap chole. So you ever had a lap chole and you find that the drain is draining bile the next day. Would you do MRCP? If yes, when? If no, why not?
If it is if I have an if I was operating surgeon, if I have a suspicion of a bile duct injury, I would keep a lower threshold of MRCP, sir. If if the drainage is significant, if it is post-operative 200 and the trend is increasing, I would do a MRCP, sir, to ensure the continuity. Or if I have suspicion of if I had troubles in trouble in securing the stick, then I would wait on it if the trend is decreasing. So I would watch the trend before I do a MRCP, and also I would see the patient clinically, sir, for signs of sepsis or any undrained collections.
So, Yuvraj, if the patient is coming to you from the next hospital after 1 day of lap chole and the drain is draining bile, would you do MRCP?
Yes, sir. To check for the continuity, I would do an MRCP, sir. Before that,
So, the essence of your answer, I guess, is that you do MRCP in all patients.
I would. The trend is while the drain output trend, I would see first before doing an MRCP, sir. And if the patient doesn't have jaundice, if the drain output is minimal, patient is clinically stable, then I would wait on the MRCP, sir. I might not do it.
So there are caveats to it. I agree, MRCP is easily accessible now, but there are caveats to it. One is that if there is a large collection or any collection sitting at the hilum, MRCP becomes practically useless. So the first step really is to see whether the patient is not septic and there is no collection at the liver hilum. Only and only then MRCP may be considered for delineating biliary anatomy. Should you do it? Well, in all patients with bile leak, theoretically you should do MRCP, but in practice, if you have a small amount of bile and you don't think there is major any bile duct injury, then you probably wait for the output to be coming down and then decide. Where would you definitely do it? Well, if you are planning a ERCP after a lab chole, you would definitely do it, whether you suspect a bile duct injury or whether you suspect a CVD stone. So, Dr. Mohan, Dr. Ramesh, you want to answer the question?
Yeah. You should explain your answers. No, you're not substantiating your. I mean, you should move away from this one-word answers. No, you should try to explain your position when you give an answer.
Shall we open this for the other faculty who joined us? Quickly, we have just got, I think we have a short time, just a minute.
Yeah, I think Yuvraj, you have predefined your approach very clearly. So the moment that there is a slight deviation, you went off the track. I think up to your presentation, it was okay, reasonably all right. But once the CT scan came in, then you were focused only on the hepatic, and then you lost the portal hypertension track. And from there, you started committing mistakes. So this does happen in the exams because examiner will try to take off from your track and then just to test you how you'll handle it. So you should, from there onwards, I observed that your performance came down, and because you are disturbed, because your thought process was in the direction of the straightforward biliary stricture, go and do HJ. Right? This does happen in the exams. And I think you are predetermined that you're going to do a CT scan. They came with MRI. So I think MRI will give almost all the information. Nowadays, many of the radiologists says we do give all the information which CT does. So in this patient, probably an ultrasound and a Doppler followed by an MR and good MR and MRI, you get all the vascular information as well in these patients. So that is one. And coming to the treatment, you said that I think you faltered on indication for PTBD. Doing PTBD for a jaundice patient is different, what Rajneesh has already explained. But in this patient, probably you might ask for a catheter preoperatively for localizing the right duct, because it is a type, ducts are separated and there is evidence of portal hypertension. So technically, probably the surgeon might feel difficulty. So the catheter in the right system, the tip of the catheter might help him in identifying the duct intraoperatively to minimize the dissection. Except for this, in this patient, there is no indication for the PTBD in this. Right? I think probably you are already predetermined that you want to go to PTBD. Right? This does happen. You must be having a knowledge, but suddenly in the exam, because the examiner tries to move off the track. So you should be prepared that change your gears and then read the examiner's mindset and come back, step back, and then rethink and then answer the questions.
Okay.
Otherwise, overall, okay. TD?
Most of the point you have already cleared. From the history point, I have mentioned in my chat box that if there is a patient of jaundice and biliary leak, and that comes after cholecystectomy, then keeping that cholecystectomy in the past history would be not the right thing to start with. And then again, as I said, we do a fibro scan when there is a patient who is coming recurrent fever and jaundice. It is more dangerous to develop secondary biliary cirrhosis, and most informative information without much issues is fibro scan, and which might have some limitation, but give some idea of fibrosis going on inside the liver. And then MR also right side was little bit less dilated, and it was looking more of a crowding type thing, and segment one was enlarged, more than larger than what is expected. So these were subtle indications which were indicating that liver is not that okay. So that was the point which I already emphasized, that at that time the person who is presenting thinking about liver getting damaged because of the recurrent cholangitis may not be higher jaundice, but recurrent cholangitis and fever low grade is much more dangerous. So these are the points, and most of the other points have already been discussed. Thank you, sir.
There's a question on the chat on the Q&A saying any role of T-tube nowadays. I'm not too sure what the question meant, but so I assume that you're asking, first part would be where in acute bile duct injury, would you place it? Well, if you have repaired a bile duct, you would repair it on a T-tube. That's the first thing. If you can't repair a bile duct, then putting T-tube limbs up to convert into hepatocostomy is what some people do. That can be individual choice. What tube you want to use to convert it into external drainage if you can't repair it. Would you place a T-tube in a patient with a hepatic jejunostomy being done for a benign biliary stricture? I don't see any place to put it. And how would you put it? I'm sure there must be one out surgeon. There is always one somewhere who would be putting it. But in the general norm of things, it is probably not indicated. Dr. Ramesh, sir, Dr. Mohan, would you like to comment on this?
Yeah, hepatic jejunostomy. Yeah, as you said, the indications are very few. If you have a transected duct and you can't do anything at that time and it is very high, probably you'll put a tube and do external drainage and come out. The other thing is across the hepatic jejunostomy, you may put a stent, but it doesn't reduce the stricture rate. It may give an access for you later on. It may give us an access for, you put a T-tube and try to bring it out. It may provide an access, that's all. So the limitations are very indicated. Very limited indications, I think.
So shall we then close this, sir? Pradeep, sir?
Yes.
Mohan wanted to say something. Yeah.
Thank you.
Anybody wants to make last comments? Okay, Yuvraj done well. As Pradeep sir pointed out, that variations will happen, and this is real world scenario also. It happens in the real world also. You'll not get a typical patient all the time. So you'll have to kind of think on your feet. Take care then. Thank you so much.
Thank you.
Thank you, sir.
Everyone. Thank you.
Thank you.
Thank you.